Welcome, Doctor.
Thanks so much for that warm introduction, and thank you to Dr. Sharmata and everybody at AIOS for having us here. It's an honor to be here. As Dr. Shriver mentioned, I'm going to be speaking today about the Avengers Endgame, dry eye and glaucoma, and I promise I will find a way to bring these two together. These are my financial disclosures. And here are the objectives I'm going to discuss today in my talk. So first, I want to discuss the global impact of dry eye and glaucoma, and then discuss some of the steps that you can take to identify ocular surface disease in the glaucoma patient, and wrap up with an understanding of the current and emerging treatments to decrease IOP while minimizing toxicity on the ocular surface. So we're going to start with a pop quiz here. Make sure everybody is paying attention. So what is the prevalence of ocular surface disease in glaucoma patients? Is it A, 20 to 30%, B, 40 to 50, C, 50 to 60, D, 70 to 80, or E, glaucoma patients have ocular surface disease? And I say that in jest, obviously. I think of ocular surface disease as Thanos. So everything bad, when he comes, when ocular surface disease is there, it wreaks havoc on the entire eye and the entire globe, and especially in combination with glaucoma. So hopefully, the good thing about being virtual is I can't see whether you got this right or not, but hopefully everybody chose B, because it's about 40 to 50% prevalence of ocular surface disease in glaucoma patients. And when we look at these comorbid conditions, we find that this is actually a global dilemma. I did a recent literature search, and you will find reports of the prevalence of dry eye and glaucoma globally. These are just a few excerpts from the Romanian Journal of Ophthalmology in Saudi Arabia, in Thailand, in Australia. There's documentation of the high prevalence of dry eye and glaucoma occurring together in populations across the globe. So this research led to a consortium that I put together of cornea and glaucoma specialists internationally to do a thorough literature review and to really understand the dual dilemma of dry eye and glaucoma. And we published this international review last December in the Asia Pacific Journal of Ophthalmology. This is an open access article, so anybody can view it at any time. You don't need a subscription to the journal, and obviously, I'm going to encourage you to read it. I know that some of you already are, because in my preparation for this presentation, I found that we are in the top 25% of all research outputs ever tracked, which made me happy, not only for the paper, but really for the bigger issue here, which is I think we've been missing the diagnosis of dry eye and glaucoma and ways that we can help treat these patients better. The DEUCE-2 task force looked at topical glaucoma medications that are considered to cause or aggravate dry eye disease. And at first, you would think maybe some of the drugs out there don't wreak havoc on the surface, are more gentle on the surface. But the fact of the matter is they found that all the classes of drugs, when they're preservatives, do indeed cause or aggravate dry eye disease. And then when you look at the adverse ocular effects in glaucoma patients when they have ocular surface disease compared to when they don't, there is significantly more glaucoma patients that have ocular effects with OSD than do not. And just looking briefly at this table, foreign body sensation, 12 times more likely. Hyperemia, 6 times more likely. Ocular pain, 12 times more likely. And we know that the presence of these symptoms negatively influences the glaucoma patient's quality of life and ultimately their compliance. Okay. The amount and duration of treatment offers further risk factors for dry eye disease in the glaucoma patients. So we know that preservatives have both a dose-dependent and time-dependent adverse effect on the cornea and the conjunctiva. The effects of BAK have been well marked in the literature. And in fact, there's some data out of an IOBS study from a few years ago showing that BAK may preferentially affect the cells in glaucoma patients because of their genetic markers. We know that glaucoma patients under treatment for 3 or more years were 5 times at a greater risk of developing ocular surface disease. So this is a significant concern. When we were looking at this global review, literally across countries and everybody finding the same problems with glaucoma and ocular surface, it really highlighted the need to have teamwork from all specialists. And what I mean by that is sometimes as glaucoma specialists, we may be only looking at the pressure, or myself as a cornea specialist, more focused on the surface. And really what this review highlights is the need for all specialists to come together and work as a team to treat these comorbid conditions, much like the Avengers had to come together to defeat Thanos, which you'll recall from the beginning of the presentation was dry eye disease. So to give you a mnemonic to remember this and to think about when you're examining your patients, I want you to think about Iron Man. So when examining the ocular surface of your glaucoma patients, I, to identify OSD early, R, recall all the tools available to diagnose dry eyes, O, to opt for preservative-free treatment, N, to note treatment options beyond artificial tears, and MAN, M, to make recommendations for alternate glaucoma therapies now. We'll go through these briefly. So first, to identify ocular surface disease early, I really think this is one of the keys to treating these dual conditions more effectively. Because when patients come in with baseline ocular surface disease that's untreated, and then glaucoma medications are added to the surface, you really are just fueling the fire. And I fully believe that ocular surface disease can be routinely evaluated in every patient that we see in clinic if you incorporate just a few pointed questions into the HPI. I've listed them here. For time's sake, I'll tell you that the one that I tend to focus on most is if they have periods of fluctuating vision. Because ultimately that's a cue to me that I need to be looking carefully at the ocular surface to see if that's contributing to their visual problems and if they have signs of dry eyes. Asking patients if they are dry, do they have problems when they're working on their iPad or watching TV for prolonged periods of time, or reading, how sensitive they are to light, and do they feel dry, painful, or sore. The R was to remember all the diagnostic tools and devices that we have to evaluate ocular surface disease. Don't forget, looking at topography can give you signs if there are areas that are missing or irregular Myers, that there's OSD. Differences in tear osmolarity, elevated MMP9. And then in looking at the literature review, we found that glaucoma patients tend to have greater conjunctival staining in the superior and nasal fornices. So that's something to look for as well. In addition, there are glaucoma medications such as the prostaglandins that are associated with a higher rate of meibomian gland dysfunction and are thought to cause meibomian gland dysfunction. And so imaging the meibomian gland of these glaucoma patients can also be key in identifying ocular surface disease. The O was to opt for preservative-free treatment. You want to consider combination therapies whenever possible and look for preservative-free formulas to be gentler on the ocular surface from the very beginning. And this paper from Tygeson highlighted how there was a decrease in concomitant symptoms of OSD when preservative-free medications were used or when patients were switched from preserved drops to preservative-free drops. The N was to note treatment options beyond artificial tears. There are a lot of things available in the dry eye world now, and they're all very important in our toolbox to tackle the concomitant OSD and glaucoma diseases. Actually, in the US, we have two different types of cyclosporin and lifitegrast. In Japan and Europe, there are more forms of cyclosporin that you have available, which is key because oftentimes with cyclosporin, it's the vehicle that's going to make the difference of what the patient can tolerate. Topical or oral antibiotics, punctal plugs, and something I've incorporated more recently in my practice has been the physical heating and expression of meibomian glands. We know that of dry eye patients, 86% of those patients, according to studies, have meibomian gland dysfunction. And so I have found in the midst of conducting a clinical trial right now on this, I found that glaucoma patients have some of the worst meibomian gland disease and therefore benefit the greatest from this form of treatment. And then the Iron Man portion was to make recommendations for alternate glaucoma therapies now. I know Dr. Pappas will be talking about innovations in glaucoma later, so I won't belabor this point, but there are a lot of innovations that are available, be it MIGS, be it sustained release implants, or as we saw in some of the most recent studies, laser therapy replacing topical drops as first-line treatment. So there are a lot of alternates that we can look at to preserve the surface in glaucoma patients. So in conclusion, it's important to recognize the high comorbidity of ocular surface disease and glaucoma. And I want you to remember Iron Man when you want to defeat Thanos. Okay, actually what I mean is that we need to work as a team in evaluating and treating the ocular surface of glaucoma patients to maximize compliance and outcomes. Thank you very much. This is all of my contact information, email, and any of the social media handles. Thank you again for this honor to present.